Good morning, everyone, and let me introduce my PhD thesis. It's titled Adenomyosis and Infertility. A bit about myself. I'm a third-year gynecology resident and a first-year PhD student. And my vision is to have improved pregnancy outcomes for women with adenomyosis. And through my projects, my mission is to find the most effective assisted reproduction protocol for infertile women with adenomyosis. For that, I have two specific goals. Let me start with the first one. It's titled Investigating the Efficacy and Safety of GnRH agonist pretreatment before frozen embryo transfers in women with adenomyosis. So, adenomyosis is a condition where the endometrial tissue invades the myometrial layer of the uterus. The exact prevalence number of the condition is not very well established, but studies suggest a report between a prevalence of 12 to 58% in reproductive age women. But why is it important? Well, women with adenomyosis have a higher risk of infertility, and even with the use of assisted reproduction techniques, their chances to achieve a clinical pregnancy is almost 30% lower than those without the condition. GnRH agonists work by downregulating the ovarian hormone production, and this can be beneficial when, in assisted reproduction techniques, we are creating and maintaining artificial hormone cycles. My aim is to investigate the safety and efficacy of the GnRH agonist pretreatment before frozen embryo transfers in infertile women with adenomyosis. So our clinical question is, does GnRH agonist pretreatment safely and effectively increase live birth rates in infertile women with adenomyosis who are undergoing frozen embryo transfers? Our population is women with adenomyosis who are undergoing frozen embryo transfers, of course. Our primary outcomes will be the live birth rates. The secondary outcomes include the clinical pregnancy rates, the implantation rates, or the miscarriage rates. And we would like to compare the outcomes with or without the use of GnRH agonist pretreatment. Our hypothesis is that endometrial pretreatment can increase live birth rates in infertile women with adenomyosis who are undergoing frozen embryo transfers. And of course, the clinical implication would be to contribute to assisted reproduction guidelines for women with adenomyosis. I've collected 3 key articles for this project, all of them studying very similar populations with the same intervention, with the same comparator groups, and reporting various pregnancy outcomes. We already conducted a systemic search in 5 databases with around 6,000 results. And after the duplicate removal, we reviewed 3,000 articles during the title and abstract selection, after which we reviewed 72 articles by full text to include 16 articles in this study in the end. In this slide, you can see our progress with the first project. We are at the data extraction phase. And now on to the second project. It's titled Comparing the Efficacy and Safety of Fertility-Sparing Treatment Options for Adenomyosis. So during the first project, we discussed the effect of adenomyosis on fertility, but this condition also causes other significant issues. For example, most commonly dysmenorrhea, but abnormal uterine bleeding or pelvic pain is also common. For the first part, we discussed the assisted reproduction treatments, but for the other issues, there are various medical and surgical techniques available. Our study focuses on the different surgical techniques, which can be either excisional, like adenomyomectomy, or non-excisional, for example, ultrasound or radiofrequency ablation. And it's important because the excisional surgeries seem to raise the risk of uterine rupture in later pregnancies by almost 6%. So finding the safest option is crucial. And also the non-excisional techniques offer an alternative for patients who are not eligible for conventional surgeries. My aim is to find the safest, most effective fertility-sparing treatment option for adenomyosis. Therefore, our clinical question is, which fertility-sparing treatment option is the safest and most effective in reducing symptom severity in women with adenomyosis? My population is, of course, women with adenomyosis, and we would like to compare the different surgical interventions I've listed before. And our primary outcome will be the effectiveness in reducing the symptom severity, and the secondary outcomes will be the reproductive outcomes. Our hypothesis is that minimally invasive techniques are safe and effective treatment options for adenomyosis. And the clinical implication would be to provide a clear guide for medical professionals who are treating women with adenomyosis. We have a preliminary search key for this project containing 2 domains, the first one referring to the population and the second one to the different interventions. This preliminary search was conducted in 5 databases, and it resulted in near 4,000 results. It already passed the feasibility check, and we checked for 3 previous systemic reviews for this project, and although there are very similar ones, but none of them are exactly framed like our project will be, and there are also no similar studies registered on Prospero. I've already conducted key articles, 3 or 4 key articles for each intervention, reporting multiple outcomes, but I believe these will be comparable in our study. As you can see, all of them report the outcomes for the dysmenorrhea symptom severity reduction, and a lot of them report pregnancy outcomes as well. And with our second project, we are just at the Prospero study protocol registration phase. In summary, we have 2 projects on the way, both being related to adenomyosis and its different treatment options. We are planning to submit the first article by next September, and the second one at the start of 2026. And I would like to end my presentation with a quote from famous astronaut John Glenn. "The one quality in an astronaut more powerful than any other is curiosity. They have to get someplace nobody's ever been." Thank you for your attention.
Thank you. Any questions from the audience?
Hello, thank you for the presentation. It was really good.
Thank you.
I have a question about the first project. We talk about GnRH pretreatment. In the articles you found, how different is this pretreatment time? Are they all the same, or are they differ from each other?
Yeah, thank you. Great question. There are different time periods for the definition of the pretreatment. Some studies report a 1-month pretreatment, others 2 or 3 months even. And there are other studies where they compare the different time periods, and they come up with the result that the 3-month period is the most effective in the pregnancy outcomes for the later IVF programs. Thank you.
Thank you.
Thank you. Great presentation, great progress. For the second project, I would like to ask, do you know which technique is the most frequently used?
Well, I believe in Hungary, the most commonly used technique for adenomyosis, the surgical technique, is conventional hysterectomy, I believe. At least that's what the most common surgical option is. But obviously, this is not a fertility-sparing option, so that's why we would like to investigate other options as well. Thank you.
Thank you so much.
One more question is, this is an important topic. Adenomyosis is one of the major factors in the infertility. Have you read, I think, because you don't have your own experience, but have you read how was achieved the diagnosis of adenomyosis? So what was the criteria for adenomyosis?
So all of the studies which are investigating this, for both the projects, there is a detailed description about the different inclusion criteria, and one of the most important one was the diagnosis by transvaginal ultrasound, the adenomyotic lesions diagnosed via transvaginal ultrasound.
Thank you. Any more questions? No more, then.
No, sorry. Based on your
preliminary results. What is your opinion about the decision? Surgical or medical treatment will be lead in the future?
I believe the combination with the assisted reproduction techniques will be used even after the surgical treatment as well. But I think for the infertile patients, if they need surgery, then it will be because of the unsuccessfulness of the IVF programs, and those patients who are not desiring a pregnancy will continue with the non-fertility sparing